much everyone for your patience, and a very good evening and a warm welcome everyone to this wonderful eve of International Women's Day.
Welcome to this webinar, Wednesday webinar of Indian College of Anesthesiologists. Today's webinar is on the topic chronic renal failure and perioperative management. So I would like to now introduce the three moderators that we have, very senior moderators. One is Dr. Manju Sarkar. She is professor and in charge, Department of Cardiovascular and Thoracic Surgery at D.Y. Patil Medical College, Navi Mumbai. And the second moderator that we have is Dr. Abhijit Paul, and he is the chief anesthesiologist and intensivist at Kolkata Heart and Lung Center. And the third moderator that we have is Dr. Janki Subhadra Peiti. She's professor at the Department of Anesthesiology and Critical Care at Shri Venkateshwara Institute of Medical Sciences, Tirupati. Over to you, Dr. Manju Sarkar, please.
So, without delaying, I would like to start the webinar. And today's topic is chronic renal failure. Our first speaker is Dr. Chaitali SenDasgupta. She is in charge of cardiac anesthesia at Government Medical College, and she's going to tell us about the physiology of the renal diseases.
Today, my presentation is on renal physiology. So, as we all know, the kidney regulates the plasma osmolarity by modulating the amount of water, solutes, and electrolytes in the blood. It maintains the acid-base balance and produces renin and erythropoietin. It also helps in conversion of vitamin D to its active form. Each individual renal tubule and its glomerulus is a unit, and each human kidney has approximately 1 million nephrons. So you can see the picture showing the nephrons. The glomerulus is 200 micrometer in diameter. It is formed by the invagination of tuft of capillaries into dilated blind end of the Bowman's capsule. And the capillaries are supplied by an afferent arteriole and drained by an efferent arteriole. The filtrate is formed from the glomerulus. The glomerular filtration is the initial process in urine production. It is a passive process in which hydrostatic pressure pushes fluid and solute through a membrane. The filtration membrane consists of three layers. They are the endothelium of the glomerular capillaries, which allow blood components to pass, but not the cells. The RBC, WBC cannot pass through the membrane. The basement membrane, it is negatively charged physical barrier. It is barrier to the proteins. The protein cannot pass through this. Food processes are podocytes of glomerular capsule. This is for more selective filtration. Hydrostatic pressure of glomerular capillaries and colloid osmotic pressure in the capsular space play the key role and make the net filtration pressure for the glomerular filtration rate. When the kidney is produced at moderate pressure, that is 90 to 220 millimeter mercury, the renal vascular resistance varies with the pressure so that the renal blood flow is relatively constant. And the glomerular filtration also happens in a constant rate. There is something called aquaporins. What are they? They are the membrane proteins. For rapid diffusion of water across the cell membrane depends on the presence of water channels. These are the membrane proteins called aquaporins. The amount of any substance that is filtered is GFR, that is glomerular filtration rate, into plasma level of the substance. The tubular cells may add more substance to the filtrate by tubular secretion. They may remove some or all of the substance from the filtrate by tubular reabsorption, or may do both. So the amount of substance that is excreted per unit of time is the amount filtered plus the amount transferred by the tubules. Sodium transport is associated with hydrogen, ion, glucose, amino acid, organic acid, phosphate, and other electrolyte reabsorption. Sodium moves from the tubular lumen into the tubular epithelial cells in the proximal tubules, thick part of the ascending limb of loop of Henle, distal tubules, and the collecting ducts. Then it actively pumped from these cells into the interstitial space. So we see sodium is actively transported out of all parts of the renal tubule except the thin portions of the loop of Henle. In thick ascending limb of loop of Henle, the sodium reabsorption is by sodium potassium ATPase, which actively pumps 3 sodium ions out of the cell and 2 potassium ions inside the cell. About 60% of the filtered sodium is reabsorbed in the proximal tubule, primarily by the sodium hydrogen exchange. Another 30% is absorbed by the sodium chloride potassium co-transporter system in the thick ascending limb of the loop of Henle. In the distal convoluted tubule, 7% of the filtered sodium is absorbed by the sodium chloride co-transporter, and the remainder 3% of sodium is absorbed via the inactive channels in the collecting ducts, and it is regulated by aldosterone. Glucose, amino acid, and bicarbonates are reabsorbed along with sodium in the early portion of the proximal tubule. It is filtered at a rate of approximately 100 milligram per minute. Essentially, all of the glucose is reabsorbed and only a few milligrams may appear in the urine in 24 hours. The amount reabsorbed is proportional to the amount filtered. Plasma glucose level into the GFR is equal to the transport maximum. When the transport maximum or TMG is exceeded, the amount of glucose in the urine rises. The TMG is about 375 milligram per minute in men and 300 milligram per minute in women. The actual renal threshold is about 200 milligram per deciliter of arterial plasma, where in case of venous level, it is 180 milligram per deciliter. Glucose and sodium bind to the sodium-dependent glucose transporter SGLT2T in the apical membrane, and glucose is carried into the cell while sodium moves down into its electrical and chemical gradient. The sodium is then pumped out of the cell into the interstitium, and glucose goes to the interstitial fluid by facilitated diffusion by the GLUT2. Like glucose reabsorption, amino acid reabsorption occurs in the early portion of the proximal convoluted tubule with sodium. Signals from the renal tubule in each nephron gives feedback for filtration in its glomerulus, and when the rate of flow through the tubule increases, glomerular filtration in the same nephron decreases. So there is a mutual understanding between the two. Conversely, a decrease in flow increases the GFR. Normally, 180 liters of fluid is filtered through the glomeruli each day, while the average daily urine volume is 1 liter. The same load of solute can be excreted in 24 hours. In a urine volume of 500 liters, when the concentration increases up to 1,400 millismol per kg, or it can be excreted in a volume of 23.3 liters when the concentration goes down to 30 millismol per kg. A key regulator of water output is vasopressin that acts on the collecting ducts. Urea also contributes to osmotic gradient in the medullary pyramids and to form a concentrated urine in the collecting ducts. Urea transport is mediated by urea transporters by facilitated diffusion. During antidiuresis, when the vasopressin is high, the amount of urea deposited in the medullary interstitium increases, and it increases the concentrating capacity of the kidney. The amount of urea varies with the dietary intake of protein. So when we take a high protein diet, it results concentrated urine, and a low protein diet causes diluted urine. The urinary system maintains blood pH by excretion of hydrogen ions as dihydrogen phosphate or ammonia, and production and absorption of the bicarbonate ions. The presence of large quantities of unreabsorbed solutes in the renal tubules causes an increase in the urine volume called osmotic diuresis. Therefore, they hold water in the tubules. In diabetes mellitus, what happens when the blood glucose is high, glucose in the glomerular filtrate is also high. Thus, the filtered load exceeds the TMG, and glucose remain in the tubules, causing imbibing more water and causing polyuria. Osmotic diuresis can also be produced by the infusion of large amounts of sodium chloride or urea. Active transport of many substances occur from the fluid in the proximal tubule, but the fluid remains essentially isoosmotic until the end of the proximal tubule. Water moves rapidly out of the proximal tubule with active transport of solutes, and isotonicity is maintained. It reabsorbs glucose, amino acids, and vitamins with sodium, and proximal convoluted tubule reabsorbs water by osmosis. From the proximal convoluted tubule, the non-reabsorbed filtrates move on to the nephron loop. This is the loop of Henle, and this filtrate comes here. It has three parts: thin descending limb and thin ascending limbs. In the thin descending limb, water reabsorption occurs here via aquaporin 1 channels. Small amounts of urea, sodium, and other ions are also absorbed, and water reabsorption occurs here by counter current multiplier system. Thin ascending limb is impermeable to water as it has no aquaporin channels. Sodium reabsorption occurs passively through epithelial sodium channels or INAC channels, and chloride ions are reabsorbed in the thin ascending limb through the chloride channels. Thick ascending limb is impermeable to water. Sodium reabsorption occurs with sodium potassium ATPase, which actively pumps 3 sodium ions out of the cell and 2 potassium ions into the cell. The overall effects of this process are removal of sodium and retaining water in the tubules. This leads to a hypotonic solution arriving in the distal convoluted tubules. As the thick ascending limb is impermeable to water, so the interstitium becomes concentrated with ions. So the osmolarity increases here. As water moves from the area to area osmolarity, water reabsorption occurs from the descending limb because the ascending limb is impermeable to water. This is called countercurrent multiplication. The distal convoluted tubule is subdivided into the early and late sections. It is the early distal convoluted tubule is impermeable to water, and it causes reabsorption of sodium, chloride, and calcium. The late distal convoluted tubule is relatively impermeable to water. It causes continuous removal of solute, leaving the solvent, and so it further dilutes the tubular fluid. So the collecting duct receives the diluted filtrate, and the collecting duct now reabsorbs water with help of antidiuretic hormone and aquaporins. ADH acts on kidney tubules to increase the number of aquaporin 2 channels in the collecting duct tubular cells. Aldosterone is produced in the zona glomerulosa cells of the adrenal cortex, and it regulates the sodium, potassium, and chloride balance in the body. It acts on the distal part of the renal nephron, collecting ducts and the tubules. Now comes to tubular secretion. The tubular secretion causes disposition of substances like drugs and metabolites that bind to plasma protein, urea, and uric acid. It causes elimination of excess potassium by aldosterone regulation at collecting duct and distal density in the tubular secretion. Excretion of hydrogen ion occurs as dihydrogen phosphate or ammonia, and production and reabsorption of bicarbonate ions occurs. The secretion of creatinine, ammonia, and many other organic acids and bases also occurs here. This is the chart showing the uptake and the filtration where it occurs. And now my presentation is completed. Thank you.
Yeah, it gives me a great pleasure to introduce Subhendu. We call him Subhendu Sarkar, Dr. Subhendu Sarkar, who is also my was also my colleague in my in several institutes where we worked together and had great time. Subhendu doesn't require much of introduction because he was quite famous, and he organized the ISA Con Calcutta very successfully. And currently he is heading the Department of Cardiac Anesthesiology and Intensive Care at the Decent Heart Institute. He was also the director of cardiac anesthesia at the B.M. Birla Heart Institute, Calcutta. And he's instrumental in setting up these two departments and developing academics in both these institutes. And his areas of interest are advanced hemodynamic monitoring, pediatric cardiac anesthesia, then VADs, ECMOs, and artificial intelligence in monitoring. As we see here that he has got an excellent academic credentials and has been winner of several awards.
So renal function test was the functions of the kidney. We all know the regulation of the body fluid and volume, electrolyte imbalance, acid, base, waste products, retention of the substance vital to the body, regulation of the blood pressure, and production of the secretion of hormones, and simultaneously production of the vitamin D3. And From the presentations what Dr. Chaitali SenDasgupta has just mentioned, I want to take some of the few points that help to understand the renal function. That about 1200 ml of the blood that passes through the kidney every minute, about 120 to 125 ml is filtered per minute and by the kidney, and this is referred as GFR. And more than 99% of this glomerular filtrate is reabsorbed by the kidney. And urine formation basically involves two steps. One is the glomerular filtration and tubular reabsorption. And filtration is a passive process and result in the formation of the ultrafiltrate of the blood. And the filtrate is almost similar composition to the plasma. So why is the renal function? To assess the functional capacity of the kidney, early detection of the possible renal impairment, severity and progression of the impairment, monitor the response to a treatment, and obviously, as a perioperative physician, monitor the safe and effective use of the different drugs which are excreted in the urine. When we should ask to assess the renal function in detail, older age, family history with CKD, diabetes and decreased renal mass, low birth weight, diabetes mellitus, hypertension, autoimmune disease, systemic infection, UTI, nephrolithiasis, obstruction to the urinary tract, drug toxicity. These are the different situations where we should ask for a detailed evaluation of the renal function. If we want to classify the renal function test, we have to go in these six broad headings. Number one is urine analysis. Number two is the blood examination. Number three, the broad heading is test for assessment of glomerular function. It actually includes the clearance test as well as the permeability component. The next one is test to measure the renal plasma flow. Lastly, test to assess the renal tubular function, and we have to divide the entire test in the proximal assessment and the distal assessment. And lastly, the miscellaneous. So let's start with the urine analysis. Just going through, we know the macroscopic examination is a pale yellow color is a normal one, normally 800 ml to 2.5 liter per day. Oliguria, if it is less than 300 ml per day. In acute glomerulonephritis, renal failure, polyuria, if the output is more than 2.5 liter per day. Diabetes mellitus insipidus, and the anuria, where the urine output is less than 100 ml per day, seen in the renal shutdown. Urinary pH is usually 4.5 to 8, and normally it is slightly acidic, lying between 6 to 6.5. But after meal, it becomes alkaline, resulting in alkaline reaction. Grossly, these are the substances: protein, glucose, ketone, bilirubin, what Chaitali has very nicely said. And if we remember the physiology slides, these are all negative, should come in the report. And centrifugation, when we go to the microscopy examinations, we have to go for the centrifugation of the fresh sample. We have to identify if there is any sedimentation, erythrocyte, leukocyte, epithelial cell, cast, fat, parasites, bacteria, crystals, is there present in the urine or not. It all depends whether the urine report is normal or abnormal, depending upon the availability of these microscopic elements in the urine. Just to remember, the substances like glucose, urea, creatinine, PAH, that is a para-amino butyric acid, and ilunin mannitol, these are the substances I have mentioned because these are all used for assess different components of the renal parameters. So if we go to the extreme right-handed column, the glucose is known excreted normally, urea less, creatinine very close, PAH more than that filtered, and inulin is equal to the GFR clearance. We'll come to the significance of that. So the next one is the glomerular function test, gross heading. This glomerular function test is actually included the clearance test. The renal clearance is defined as the substance that is defined as the volume of the plasma from which the substance is completely cleared by the kidney per minute. This is the definition of renal clearance of any substances. And the glomerular function test is headed under plasma urea clearance, plasma creatinine clearance, calculated creatinine clearance, which is called eGFR, inulin, isotopic technique, cystatin C, and plasma beta-2 microglobulin. These are the all tests comes under the heading of glomerular function test. The first one is the GFR. The normal GFR is 120 to 130, and in a CKD, if the GFR is less than 60 ml per minute per 1.73 meter square for 3 months or more, with or without any kidney damage, we call it CKD. And depending upon, if we can see the chart, depending upon the degree of the GFR, we can categorize the degree of the CKD starting from the minimal damage to the end stage renal disease. Now the clearance stage. Grossly, what I have already described, the clearance is defined by the volume of the plasma that would be completely cleared of a substance per minute, and it is calculated in the form of the UV by P. U stands for the concentration of the substance in the urine, V for the volume of the urine, and P for the concentration of the substance in the plasma. And this 1.73 square meter for all clearance values are adjusted to a standard body surface area of this 1.73 square meter. So it's a fixed value. And agents that is used for the GFR analysis, it can be an exogenous substances, it can be an endogenous substance. Among endogenous, it is urea, creatinine, and cystatin C. For exogenous, usually the inulin is the first choice. So first one comes the at normal level of the creatinine, this metabolized is filtered at the globule, but neither secreted nor reabsorbed by the tubule. Hence, its clearance keeps the GFR. The convenient method for the estimation of the GFR, because it is normal metabolites of the body and doesn't require any intravenous administration or test material. And estimation of the creatinine is very simple. The procedure is accurate 24-hour urine sample is collected, collect a blood sample of the serum creatinine determination, and estimate the serum and urinary creatinine concentration. Usually 95 to 105 ml per minute is the normal creatinine clearance. The next one comes the urea clearance. It's a maximum clearance when the urine output is 2 ml per minute. The most important thing is urea clearance of 70% indicates of normal functioning. If we come to the yellow box, the 1, 2, 3, if the urea clearance is more than 70%, renal function is normal. If the clearance is between 40 to 70, the renal function is mildly impaired. And if the urea clearance is less than 20%, renal function is severely impaired. The serum urea. The normal to 40 serum concentration increases at the age advances, and we all know from our student life the pre-renal, post-renal, and the drugs. These are the 4 components or causes where we can find the increase in the blood urea. Among the pre-renal, dehydration, vomiting, intestinal obstruction, diarrhea, renal, acute glomerulonephritis, nephrosis, malignant hypertension, in the urinary, and drugs. These are the very important AC inhibitor, acetaminophen, aminoglycoside, amphotericin, diuretics, and particularly the NSAIDs. These are the important drugs where we may have found this patient has sudden rise in the serum urea. Now the serum creatinine. For an adult male, 0.7 to 1.3, and adult female, 0.6 to 1.1. Decrease and increase. The decrease if there is a low muscle mass, female malnutrition, thiazide, diuretics, and in an increase in an old age male, glomerulonephritis, pyelonephritis, renal failure, and all the different conditions. The next one is previous one is the serum urea, and now is the blood urea nitrogen, that is called BUN. Urea is produced in the liver from the amino acid, and the concentration of the blood urea is usually expressed as blood urea nitrogen. The normal level is 7 to 8. Causes of the increase, it can be because of pre-renal azotemia, renal azotemia, or the post-renal azotemia. The next one is the inulin clearance test by using the exogenous substance. Till now, the endogenous is over. It's the ideal substances. It's an exogenous. The normally is 125 ml per minute range. It's 100 to 150 ml per minute clearance. And inulin clearance into 0.6 is the maximum urea clearance. And we all know from the previous chart that inulin is equal to the GFR. So it has to be 100% come out. The next one is a cystatin C. frequently we found the nephrologist prescribe these tests whenever we send for any referral for analysis if the patient is having renal function or a compromised renal function preoperatively. The inhibitor of the cysteine proteinase produced by all nucleated cell, there is not absorbed, not secreted, and metabolically altered by the renal tubule, not affected by the muscle mass, sex and race, high isoelectrolytic point, sensitive changes in the creatinine blind area, extremely sensitive to monitor GFR, and measurement is expensive and difficult, need IV administration. Normal value is 120 ml per minute. The next gross heading is test for glomerular permeability. It's actually where we assess the proteinuria component. The first sign of the glomerular impurity, even before there is a decrease in the glomerular filtration rate. So permeability tests are of the proteinuria. Now the normal protein excretion is less than 150 milligram per 24 hours. If there is a damage, it is a glomerular proteinuria. If there is increase in the low molecular weight protein overflow and decrease in the resorptive capacity, is a tubular proteinuria. The microalbuminuria or minimal or the polyalbuminuria, if we found 30 to 300 milligram per day in the urine, and this is the earliest sign of renal damage because of the diabetes mellitus and hypertension. And obviously, when the disease goes on progress, we can categorize the amount of the proteinuria we are finding because of the increased glomerular permeability. And this is a practical application, the diabetic nephropathy according to the urinary albumin level. These are the different gold, silver, and the bronze standard. This well-known chart available. There are different types of examinations as a marker of the glomerular filtration rate. And these are the substances of, we need to remember the threshold value of the blood of, this is the substances of the blood value. If it goes above, it actually crosses the threshold and we can get these substances available in the urine. The next component is test to measure the renal plasma flow. The two gross heading, one is a filtration fraction and next is the para-amino hepurine. The filtration fraction is a calculation of CIN by CPH, or we can make it as a GFR or divided by renal plasma flow is 0.217. The normal range is 0.16 to 0.21. And because of the essential hypertension, malignant phase of the hypertension, and glomerulonephritis, these are the different situations where the renal plasma flow measurement to analysis the filtration fraction is one of the very good predictor of the situation of the disease. The para-amino hepurine is the clearance is a method used in the renal physiology to measure the renal plasma flow, which also is a measure of the renal function. And PAH is completely removed during a single blood circulation through the kidney at low blood concentration of the plasma. Component is the test for the tubular function. We have some tests for assessing the proximal renal tubular function, some tests for assessing the distal renal tubular function. The proximal one is in the form of the glycosuria, generalized amino aciduria, tubular proteinuria, urinary concentration of sodium, and fractional excretion of sodium. And the distal tubular function, we have to assess the urinary specific gravity, urine osmolality, water deprivation test, and ammonium chloride loading test. Among this water deprivation test is we have to be a bit careful if the patient is having a good amount of the moderate degree of the renal disease or the patient is having cyanotic heart disease. This water deprivation test is better to avoid. The last one in the miscellaneous group is the renal biopsy. The importance is to establish the diagnosis, assess the severity and activity of the disease, assess the prognosis by note amount of the scarring, and to plan the treatment and monitor the response to the therapy. The indications of the renal biopsy: nephrotic syndrome in adults, nephrotic syndrome not responding to the corticosteroid, acute nephrotic syndrome for differential diagnosis, unexplained renal insufficiency, asymptomatic hematuria, isolated non-nephrotic range proteinuria with a renal impairment, impaired function of the renal graft, and involvement of the kidney disease like systemic lupus erythematosus. So these are the different indications of the renal biopsy. And this is my last slide. I didn't include the blood sodium, potassium levels and other. These are the all miscellaneous group investigations that actually not a direct indicator or the predictor of the renal function, but what we have described in segment wise, these are the helps us in identifying not only the jeopardized renal function, also simultaneously where the disease is actually lying. So we have a glomerular dysfunction and a tubular dysfunction. Usually in glomerular, there is an increase in the serum urea, increase in the urine clearance decreases, urine volume comes down, specific gravity increases, dysfunction, there is a gross decrease in the urinary concentration, and dilution tests are abnormal, uric acid excretion comes down, blood uric acid increases, acidification of the urine comes down, it becomes more alkaline, amino aciduria present, urine volume increases, specific gravity decreases, and phosphate decreases. So these are the basic difference between the glomerular and the tubular dysfunction. And then according to the available data, we need to again identify whether the problem lies with the proximal tubular dysfunction or a distal renal tubular dysfunction. Thank you very much for patience listening.
May I have the pleasure of introducing our next speaker. Dr. Saikat Sengupta is currently working as a senior consultant and academic coordinator from Apollo Multispecialty Hospitals in Kolkata. His areas of interest are teaching and training, quality and safety in clinical anesthesia, thoracic anesthesia, transplant anesthesia, regional anesthesia, and onco anesthesia. He's got plenty of publications and awards and peer-reviewed journals. 61 is a good publication number. Over to Dr. Saikat Sengupta.
It is my pleasure today to talk about what we have as biomarkers and what could be interesting in biomarkers in kidney disease, and which is why I have kind of tweaked the topic a bit, and we'll be discussing
Dr.
about
Saikat
new
Sengupta?
biomarkers in kidney disease and how it can influence anesthetic management. Biomarkers is nothing but a biological molecule found in blood, other body fluids or tissues that is a sign of normal or abnormal process or of a condition or disease. A biomarker may be used to see how well the body responds to a treatment for a disease or condition, and it is also called a molecular marker or a signature molecule. The biomarkers of renal disease, which are being currently used, quite popular, quite common, are things like the urine output, serum creatinine, and in some extent, the cystatin C. Both the urine output and serum creatinine are functional markers, unfortunately not great in damage marking. And though urine output tends to can change within an hour, serum creatinine takes about a day and more for it to be manifested. And which is why there has been interest in these new biomarkers like NGAL, IGFP7, TIMP2. And we'll talk about that as we go through it. Currently used urine output and creatinine used for the diagnosis of AKI, but are far from perfect and have a very low specificity and sensitivity. We know that AKI is a syndrome with multifactorial causes, and it is very difficult to have a specific attribution of AKI where you can specifically say that it was that intraoperative event which caused it. And therefore, early detection and prevention of AKI, which is very important because the detrimental effects can set in if you have not recognized and prevented and treated it. It remains underestimated, but it is a very important clinical complication, And unfortunately, as we realize, because this is noted with delay, the complications can becomes evident post-operatively. It may not always need organ support, but there could be short and long-term morbidity and mortality for patients. Patients can get into chronic kidney disease, end-stage renal disease, and become dialysis dependent, and can lead to increased bleeding, cardiovascular morbidities, infection, delirium, and also mortality. We have certain obligations and responsibilities like prevention of hypoxemia and hypothermia, minimizing avoidable intraoperative renal insults, and especially taking greater care of vulnerable patients. But we also need to now figure out which is a reliable way to identify high-risk patients and therefore timely implement preventive and therapeutic measures so that even if there is an insult, it does not progress to further deterioration. The problem with urine output and serum creatinine. Let's take urine output. The measurement of intraoperative urinary output, as we have always realized, is not very reliable. A decline may be attributed to the release of the antidiuretic hormone as a response to the surgical stimuli, the anesthetic implications, the relative hypovolemia that there may be patient, and increased use of opioids. It could be also, you realize, it may be an appropriate renal response to hypovolemia or the reduction of blood pressure beyond the limits of renal autoregulation. Then there are these mechanical things like obstruction of parts of the urinary tract or the indwelling catheter, which can decrease the urine output. So they are not always extremely reliable. Creatinine also has its own limitations. It depends upon the functional reserve of the kidneys. And we know from our years in medical school that a reduction of glomerular filtration rate by greater than 50% is necessary before a rise in serum creatinine can be detected. The value itself can be influenced by muscle mass, dietary protein intake, and unfortunately, the diagnosis of AKI based upon creatinine can be made after the kidney has already suffered substantial organ damage. The need to change is obvious, and we realize AKI is a time-critical process, and there is always a better chance of resolution and full recovery the sooner it is detected and the earlier it is treated. This is the classical pictorial representation. We realize that AKI and CKD are a continuum and they're not discrete separate entities. AKI can have it because of an abrupt decrease in renal function over 7 days or less from a normally functioning kidney, leading to progression of the injury beyond 7 days to lead to an acute kidney disease. And when this is persistent greater than 90 days, we get into the spectrum of chronic kidney disease. The initial renal injury due to an insult or exposure to a noxious environment is potentially reversible. What is critical is to identify this when it is happening. And if you do not, and the failure to intervene results in progression to a more severe and ultimately permanent damage, eventually resulting in permanent loss of function and getting into chronic kidney disease. And this is again, like if there is repair and resolution, you go back to the near healthy status. And if you do not, then you can progress to CKD. The progression is not dissimilar to other organs. It's pretty similar. Like in heart, you'll get a cardiac angina, and then it will progress to MI and then cause impaired cardiac function. In the brain, you can have a cerebral ischemia leading to an ischemic stroke with permanent neurological deficit. The dissimilarity is AKI is a complex syndrome. It is not only happens because of an imbalance of supply and demand. It is one of the potential causes, but it can be due to different causes, including direct toxicity from medications or even from cytokine release in sepsis leading to AKI. And in in a cardiac patient or in a cerebral attack, when there is cardiac angina, there is chest pain. So there are symptoms. Cerebral ischemia, you can have headaches or neurological findings. Unfortunately, in renal angina occurs silently, and functional deficits only become evident with significant delay, which is why you need to have a way of finding it out when it is happening. The timely intervention can preserve residual organ function, and that is true for the kidney as well, just like it is true for the heart and for the brain. And if it goes unnoticed, the kidney damage occurs. It cannot be diagnosed immediately by the conventional biomarkers that we have, and we then have a subclinical AKI because we are not able to pick it up. The role of these new biomarkers, therefore, will be in detecting ongoing renal damage in the absence of biochemical evidence to fill this diagnostic gap and give clinicians the opportunity for intervening early. And also, if you have a point of care testing, it becomes much, much better. The new renal biomarkers are these low molecular weight proteins, the tissue inhibitor of metalloproteinase 2, TIMP2, insulin-like growth factor binding protein 7, IgGBP7, which can predict the development of moderate to severe AKI within 12 hours of an ICU admission. It is released from the renal cells when they are entering the G1 cycle arrest, a response to prevent replication of the damaged DNA. And both as a individually and as a product can have a greater predictive effect, and there are quite a few meta-analysis which is shown that the specificity, sensitivity, diagnostic odds ratio, the area under the curves are good to come to a diagnosis. And especially for looking at surgical, there is enough evidence in cardiac surgical population that it can be used to detect it early. The other one is the neutrophil gelatinized associated lipocalin, NGAL, and both from the neutrophils and tubular epithelial cells. And in pediatric and adult patients undergoing cardiac surgery, the NGAL scores have been shown to appear much earlier than creatinine, 1 to 3 days earlier. So the possible role, I'll reiterate, is now for the first time that we can identify, like nephrocheck, to at-risk patients for AKI early enough, and so that you can prevent them and initiate therapy. So this is what we had as a prognostic marker. Urine output creatinine was not great, and as a damage marker, they were never great, whereas you find that the NGAL and IGFBP7 and the TIMP2 are very good as damage markers and as very good for prognostic markers, appears early, and can be promising in the clinical. There are also other things. I will not talk about them today. And this can lead to possible interventions in the perioperative period, like you optimize your fluid management, optimize hemodynamic targets, optimize what kind of fluids, and you individualize therapy. So to sum it up, the key points that we should remember that renal injuries lie on a spectrum from AKI to CKD, and it is a time-critical syndrome that requires timely intervention to prevent further potentially irreversible damage. The current functional biomarkers like creatinine and urine output are reliable over a wide range of patients, but detect AKI with delay and after substantial damage has occurred. The use of these new biomarkers like TIMP and NGAL can enable clinicians to detect AKI at the early stage where preventive measures can be started, and that has the highest chance to avert progression to permanent damage. Thank you very much for a patient hearing.
Thank you, sir. That's a very informative lecture and very useful in our clinical practice.
I'm very privileged and proud to introduce Dr. Kalyan Ram. He is a consultant cardiac anesthesiologist and working as a private practitioner. And his area of interest is cardiac patients for non-cardiac surgeries. As all of us knows that cardiac patients to deal in cardiac theater is very easy because cardiac theaters are well equipped and everything is available there. All advanced hemodynamic monitoring is available there. But doing the cardiac patients for non-cardiac surgeries in other theater, it is really difficult because that much of infrastructure is not available, and early diagnosis and treat them is really need attentive presence of your as a cardiac anesthesiologist. He is interested in critical care management and ECMO too. And he is going to tell us about the anesthesia for renal transplant. So over to you, Dr. Kalyan Ram.
Good evening, everyone. And today my topic of discussion is anesthesia for kidney transplantation. I made it in such a way as a difference in management from any other major cardiac case with comorbids. Some obvious things like preoperative monitoring, preoperative investigations may not be discussed. Coming to indications, end-stage renal disease is the main indication for kidney transplant, as we all know. Glomerular disease, congenital disease, and polycystic kidneys are indications in young patients. Nephropathies associated with diabetes and hypertension form the major chunk of the waitlisted patients, which accounts around 70% of the patients. And nowadays, renal graft failures are more common, and it accounts for around 10 to 15% of the patients. Coming to pathophysiology of end-stage renal disease, when a chronic kidney disease reaches to a state where there is significant decline in glomerular filtration rate, and there is increased uremia, and oliguria is also increased, and abnormalities of fluid and fluid balance and electrolyte set in, and the main functions of the kidney are affected, like maintenance of plasma volumes, which leads to expansion of extravascular fluid, which leads to edema, hypertension, and volume overload. And there may be disorders of another function of kidney is maintenance of plasma ion composition. When it is disturbed, disorders of sodium, potassium, magnesium, calcium, and phosphorus can occur, which leads to chronic disorders of bone metabolism, hyperparathyroidism, and vascular calcifications can occur. Especially hyperkalemia has direct effect on myocardium, so myocardial effects are more in hyperkalemic patients. And elimination of organic acids is another function of kidney, which is deranged, which leads to anion gap metabolic acidosis. Coming to cardiovascular system, end-stage renal disease has significant effect on cardiovascular system. In fact, most common cause of morbidity and mortality in end-stage renal disease is due to cardiovascular disease. It accounts for around 40% of the patient. Ischemic vascular disease occurs in these patients because there is an acceleration of atherosclerosis in all end-stage renal disease patients, which leads to not only coronary but also cerebrovascular and peripheral vascular disease. Atherosclerosis is present. Occurrence of CAD is common in these patients, which presents as angina, myocardial infarction, or sudden death. It accounts for around 40% of the patient. Hypertension is both cause and effect of the end-stage renal disease. 30% of the patients of end-stage renal disease occur due to hypertension, and due to hyperreninemia post-ESRD and renal vascular changes and expansion of extravascular volume, hypertension occurs in end-stage renal disease patients. And due to hypertension, there is left ventricular hypertrophy and diastolic dysfunction, which are most common echocardiographic changes in end-stage renal disease patients. On contrary, dilated cardiomyopathy with systolic dysfunction can also occur in these patients. Cardiorenal syndrome occurs in all end-stage renal patients, which is an interconnection between both. There is interconnection between both cardiac and renal systems. When function of one system declines, automatically kidney function also decreases. It comes as it may present as arrhythmias in these cases, and heart failure and arrhythmias are common in cardiorenal syndrome. Pericardial disease occurs due to uremia and due to increased cardiac output from arteriovenous fistulas. In these cases, it may present as pericarditis or pericardial effusion. Hematologic system, as synthesis of erythropoietin is a function of kidney. When it is affected, normocytic normochronic anemia sets in all these patients, and erythropoietic stimulating drugs and iron are commonly used in end-stage renal disease patients. There is abnormal hemostasis, mainly due to defects platelet dysfunction. Both adhesiveness and aggregation is affected, and there is decreased production of von Willebrand factor and factor VIII. Historically, these patients are considered as major risk for bleeding. On contrary, hypercoagulable states also exist, which is a complex hemostasis, which is due to the reduced antithrombin levels and increased fibrinogen and some endothelin factors. There is also DVT, pulmonary embolism, and thrombosis of vascular line insides and arteriovenous fistulas can also occur in these patients. Gastrointestinal system is also affected. The most common symptoms are nausea, vomiting, and abdominal pain. Dyspepsia is also a major symptom. It occurs around 70% of patients. And delayed gastric emptying due to uremia can occur around 50% of the patients. Next, central nervous system and neuromuscular abnormalities. Mild symptoms like memory and attention deficits are common. And signs and symptoms of neuromuscular irritability can also occur in many patients. Peripheral neuropathy is present in almost 90% of the patients with end-stage renal disease. Autonomic dysfunction is present around 50% of the patients, which is manifest as orthostatic hypotension, cardiac arrhythmias, etc. Uremia causing asterixis, seizures, and decreased mental status is rare in these patients. All these effects, 99% of the effects will be reversed by renal kidney transplantation. Coming to preoperative evaluation, main focus of our preoperative evaluation should be on multi-organ manifestations of end-stage renal disease. And our main goal should be risk stratification of the patient and optimization of medical status of the patient. Cardiac evaluation, our major preoperative evaluation will be based on cardiac evaluation because, as I told, major mortality and morbidity occurs due to cardiac status of the patient. The focus should be on occult ischemic heart disease and identifying the disease. So stepwise algorithms will help in identifying the known patients with CAD and CAD risk factors. And we should estimate the occurrence of major adverse cardiac events in this patient, which is called as MACE, based on both clinical and surgical risks. And finally, functional capacity of the patient, which is measured by metabolic equivalents. So moderate to good exercise metabolic equivalents can be eliminated from further testing. And those patients who have less than 4 metabolic equivalent should be done for further non-invasive testing. Silent MI is common in these patients, and patients with MI not presenting with angina are more common, and especially in diabetes with end-stage renal disease patients may not present with MI. So further testing is very important in these patients, especially those who have less metabolic equivalents. So further non-invasive testing generally done by dobutamine stress echocardiography and myocardial perfusion imaging. Although these tests are not reliable because of chronotropic incompetence, so maximum heart rate may not be achieved in dobutamine stress echocardiography. And myocardial perfusion, the problem is response to vasodilators may not be as good as in normal patients compared to ESRD patients. They may give false negative results, but a positive test definitely indicates that major cardiac events can occur, but a negative test should not be taken seriously in these patients. 2D echo is a must for all patients in preoperative evaluation, and known cardiac patients on follow-ups continuous 2D echo should be done for major any changes in systolic left or right ventricular function, any changes should be noted. So in asymptomatic patients, non-invasive ischemia testing is done if 3 or more of the factors is present. If there is a known CAD, diabetes, or dialysis greater than 1 year, age greater than 60 years, smoker, left ventricular hypertrophy, dyslipidemia, or hypertension. If 3 or more of the factors are present, even if the patient is asymptomatic, further non-invasive testing can be done. Occult pulmonary hypertension can occur in around 40% of the patients. It is mainly due to uremia, and it is one of the major risk factors. Cardiovascular medications like statins, these people use statins, alpha-2 agonists, AC inhibitors, calcium channel blockers. All these medications should be continued through the perioperative period. Good glycemic control at around less than 200 mg should be maintained for all patients preoperative. On the day of surgery, regular dialysis as per schedule should be continued for the patient, and if possible, dialysis immediately before surgery is good for patients. Potassium levels are of critical importance. Hyperkalemia, which is greater than 5.5 milliequivalent, should be taken seriously, and we may delay surgery or take the patient post dialysis. Volume status of the patient is important, which is measured by vitals. Continuous monitoring on the day of surgery is important for the patients. Dry weight, which is euvolemic weight of the patient, should be noted preoperatively. And the current weight should be compared with the dry weight, which gives us a good estimate of the extravascular volume of the patient, whether the patient is hypervolemic or hypovolemic, or volume resuscitation can be done or not. Blood reserve, generally kidney transplantation does not have much blood loss, but as surgeons are dealing with major vascular structures, anytime sudden bleeding can occur, so adequate blood should be cross-matched and kept ready in case of emergency. On the day of surgery, a bedside 2D echo for recent changes in left or right ventricular function is warranted in these patients. Intraoperative management, generally it is done with general anesthesia with endotracheal intubation. Antacid prophylaxis is a must for these patients and is of critical importance because there is delayed gastric emptying in these patients, and it is generally done by H2 receptor blockers or some non-particulate antacid half an hour before surgery. Squalene versus rocuronium, generally a modified rapid sequence induction is preferred in these patients due to this gastric emptying issue. If you give squalene, there is a chance of mild increase in potassium around 0.5 to 1 milliequivalent for about 10 to 15 minutes before it comes to baseline. So taking the potassium level is important preoperatively. Rocuronium also can be preferred, but there is a prolonged action of rocuronium in all end-stage renal disease patients. Pressor response should be attenuated in all patients, especially chronic hypertension patients. Maybe more pressure response may be present, and mild doses of opioids or loxicod can be given to for the pressure response. Monitoring, all basic monitoring should be done. Apart from that, arterial line is preferred in some patients like already known cardiac patients, and where there are some obese patients where the surgery may take a long time because of deep anastomosis. Multiple veins, 2 or 3 veins and 2 arteries have to be anastomosed, which may take a long time because later we may need arterial bloodless analysis for these patients. And chronic hypertension patients also, to maintain BP adequately, arterial line is preferred in some patients. Generally, the arterial line is kept on the side where AV fistula is not present, and femoral line is generally not preferred. If at all it is needed, it should be kept on the opposite side where transplant is done. CVP line, generally we prefer CVP line because many centers do not go for a CVP line, but it may be beneficial to transfuse immunosuppressive drugs, vasoactive medications if at all needed, and for volume resuscitation. Because central venous pressure generally either volume responsiveness or status cannot be measured in these patients based on CVP. For maintenance of anesthesia, isoflurane gives prolonged duration. Desflurane, we have to give more MAC, which may be costly. Sevoflurane is generally a reasonable choice in these patients. And the formation of compound A and fluoride is not that much common as per studies. Muscle relaxants, cisatracurium and atracurium is preferred. Curonium, rocuronium generally avoided in these patients for fast recovery. Analgesia is done with the short-acting opioids like fentanyl, sufentanil or remifentanil if available. Morphine is generally avoided because there is variability in cases. Recovery, after patient is completely recovered, we should expect where the patient can maintain his lower airway. Again, the risk of aspiration is more because of delayed gastric emptying. Coming to surgical procedure, renal allograft is placed in either in extraperitoneal fossa of the patient, either right or left side of the patient. So preferably right side. The incision is given as a vertical incision from suprapubis to above supraclavicular line. Around it is 20 to 25 centimeters. The kidney is placed, and the first generally there is a difference where surgeons anastomose generally external iliac vein and artery anastomose. In our center, the anastomose internal iliac vein and internal iliac artery. After first the vein is clamped and renal vein is anastomosed, and afterwards the artery is clamped and artery is anastomosed. During the anastomosis time, balanced crystallite salt solution should be infused to maintain extravascular volume in these patients. And post-anastomosis, once clamp is released, reperfusion syndrome can occur and hypotension can occur. At that time also, volume infusion to maintain adequate BP, because hypotension can cause renal thrombosis and underperfusion of the kidney. So to avoid those, and before clamp is released, before clamp is placed, heparin may be infused, and before clamp is released, generally we infuse around 100 mg of furosemide and mannitol to stimulate the diuresis in the donor kidney. So intravascular expansion during this thing, as I already told, diuretic and mannitol. Immediately after release of clamp, in very rare cases, acute bleeding may occur, so we should be ready for resuscitation and blood should be kept ready. Hypotension during reperfusion should be avoided. We may reduce the volatile anesthetic a bit, and with volume expansion, many patients will settle in. Some patients where the anastomosis may take long time may have some hypotension issues. In those cases, vasoactive medications can be added. Generally, we start a small dose of norepinephrine because we can't use more doses because renal vasoconstriction may occur. Extubation after complete recovery should be done. Mostly it will be done in OT, but there is no urgency. Depending on the patient condition, extubation should be planned. Postoperative management. Generally, common postoperative complications of decreased urine output. If it is pre-renal cause, we should do volume resuscitation. Post-renal, generally, ureteric anastomosis is a common problem, and patient should be taken in and the repair should be done. Surgical complications of vascular thrombosis, hematomas, and infections can occur. Non-surgical complications, both pulmonary and cardiac complications can occur. Postoperative pain control is generally done by electrodes, and it is variable in many patients. Some patients may have severe pain and because of chronic dependence of opioids in these patients. Generally, renal anesthesia is controversial in these patients. Generally, in our center, we don't use renal anesthesia in case. And thin patients where there is a good coordination with surgeon and anesthesiologist, renal anesthesia may be preferred. Organ matching, both ABO, cross-match and HLA match should be done in all patients. HLA mismatch, generally we use thymoglobulin or grapholon, which is ATLA. Thymoglobulin dose is around 3 to 6 mg per kg, but it costs around 1 lakh for 4 days. Grapholon cost is around 6 to 9 mg per kg, which costs around 40,000. Nowadays, people are using grapholon, which has less side effects. Thymoglobulin is in HLA mismatched patients. Basiliximab is generally used in good HLA matching first degree relative patients. It is given as 2 doses, 20 mg on the POD 0 and POD 4. Thank you.
Thank you, Dr. Ram, for excellent presentation on renal transplant and anesthesia. Now we will move on the next speaker of the session.
Dr. Muralidhar, sir, you don't need any introduction. And but yeah, it's an honor for me to introduce sir. And we all know Dr. Muralidhar sir, and he's been the academic director and professor and senior consultant at the Narayan Hrudayalaya Health City. And he started the B.M. Birla Heart Institute way back in Calcutta, as well as the NH Health City, Narayan Hrudayalaya Institute of Cardiac Sciences, and the Mazumdar Shaw Institute. And I had the privilege of working with him in NH in Bangalore. And sir, the podium is all yours, and I think you would speak on the genetic predisposition of genetic predisposition to kidney injury, which is the topic for today.
Thank you for the kind introduction. And I would like to thank everybody who is in the meeting for joining us on this great day of International Women's Day. The topic for discussion is about kidney disease. And to sum up the session, I will be dealing with the genetic vulnerability to acute injury. What is the current status of understanding on this subject? You know that the estimated 1 million patients undergo cardiac surgery throughout the world each year, and about 150,000 patients undergo cardiac surgery annually in India. And when these subjects undergo cardiac surgery, there may be a renal insult which can occur. This renal insult is multifactorial, which I'll be mentioning it one of my later slides. And if you go by definition, by increasing the serum creatinine and urine output criteria, the incidence of acute kidney injury is up to 20 to 30%, depending upon the type of definition used. Any rise in the serum creatinine by 0.3%, 3 milligrams per cent, qualifies it to be called as acute kidney injury. And going back by that criteria, 30% of the patients develop acute kidney injury. But most often, this kidney injury is self-limiting. By about 7th day, the creatinine has come down to its normal level and there is no subsequent issues. But in about 2% of the patients, this renal injury is of such severity that they will need renal replacement therapy. And when they need renal replacement therapy, the mortality rate is close to 50%. And the survivors may become chronically dialysis dependent. The several factors which are influencing the occurrence of kidney injury is mentioned in this slide. This can be from the preoperative. This can be preoperative risk factors. Is the screen fine?
Sir, you are in the presentation mode. You can go.
I don't know. It's automatically jump to that. 1 minute. I'll just.
You could put it in the full screen, sir. Yeah, now it's okay.
Yeah. So there are preoperative risk factors and there are risk factors intraoperatively and postoperative risk factors. And at each stage, we could check on the risk and then modify the as per recommendations. And if you look at the creatinine increase, it depends upon the degree of injury. The dramatic effects of magnitude of injuries represented in this slide. This is the percentage on the vertical axis, percentage of on the vertical axis, we have the percentage increase in creatinine, that is the change in creatinine. And these blue circles represent the average, daily average creatinine, which is measured up to the 10th day of surgery. Starting from preoperative, the first post-operative day, second, third, like that. And each of the disease processes which have been treated surgically are mentioned in the horizontal axis. This is the port axis surgery, off-pump CABG, CABG on pump, valve surgery, CABG plus valve surgery, heart transplantation, and lung transplantation. Heart and lung, double lung transplantation. As is evident from this picture, as this magnitude of injury increases, the rise in the creatinine is proportionate to the magnitude of injury. But if you look at this point, you can see that the creatinine actually has come down because of the factor of hemodilution, which occurs in cardiac surgical patients, especially when you put the patients on bypass. So several workers have looked into looked to see if there's any genetic predisposition to acute kidney injury in these patients, because of the fact that the observation is that two patients having the same stress risk factors may behave differently when subjected to this insult. So this led to the thinking that there may be some genetic influences, and which has been identified, and at least 9 genetic markers have been identified in the Caucasian population. And this study also demonstrated in Singapore in the Southeast Asian population that the population-based studies are necessary to identify the genetic predisposition to kidney injury in these patients. This is the schematic arrangement of typical human genome with locations of gene polymorphism, and the genes are analyzed by genome-wide analysis, and any polymorphism, that is change in the normal change in the amino acid sequence in the gene, is identified, and several such small changes are added together to give a polygenic risk scoring. And depending on that, we could identify the genetic polymorphism which may be present in these patients, which may predispose these patients to acute kidney injury when they are subjected to cardiac surgical procedures. One of the important contributors of kidney injury is tumor necrosis factor alpha, which is again genetically influenced, and its concentration may increase depending upon the polymorphism, and may be an important contributor to the kidney injury. The second factor which is identified is the angiotensinogen, which is a vasoactive product which causes vasodilatation, and it may be it's normally secreted. It is produced by the kidney and is in response to hypovolemia or hypotension. Renin is secreted from the juxtaglomerular apparatus, and that converts angiotensinogen to angiotensin 1, which is converted into angiotensin converting enzyme to angiotensin 2, which has widespread vasoconstrictive effects. And this has been identified as one of the factors which may be responsible for decreased renal function in kidneys in these patients. These are some of the genetic studies which have demonstrated the presence of the gene abnormalities. The dark red ones are the ones which are causative for the occurrence of renal dysfunction. In our own center, what we have done is we have looked at the genetic factors that may cause kidney injury in patients undergoing off-pump coronary artery bypass grafting. We had a cohort about close to 2,000 patients, and these patients were categorized into 4 groups, namely the four groups. The first group was those with the normal renal function, which is defined as GFR of more than 60 ml per minute per meter square of body surface area with a creatinine of 1.3 or less. The second category is those with renal dysfunction undergoing cardiac surgery with a creatinine of 1.3 or greater with the eGFR of less than 60 ml per minute per meter square of body surface area, 1.73. And patients with kidney disease with no symptomatic heart disease or known heart disease. And D patients were age-matched healthy control population. So these the genetic testing was done, subjecting them to global screening array using special techniques. And in the group 1, group A and B, KIDIGO criteria were used to identify AKI, that is the kidney disease improving global outcomes criteria were used to identify the development of AKI. And then based on this, the findings were extrapolated, and these findings were presented to the American Society of Anesthesiologists meeting 2 years ago in 2019, I guess. And this study found genetic polymorphism that may be implicated in acute kidney injuries in patients undergoing off-pump CABG. So identification of such factors, this is the technique used, and this is called as the Manhattan plot, and it is with the chromosome 11 numbered, which there were some indication that this gene may be responsible for kidney injury in these patients, which was not present in those patients who did not develop kidney injury. And when we applied the global, the coronary artery disease polygenic risk score, that had no implication on the occurrence of acute kidney injury. Based on this finding, we concluded that there is a significant genome-wide association signal observed in chromosome 11 in causing acute kidney injury in off-pump CABG patients. And we need to confirm this in a larger subset of patients. And this, if our findings are confirmed, we could pave the way for development of predictive scoring systems, more reliable biomarkers, and novel preventive technologies. And with this, I would like to congratulate the women. All the women are participating here and others who are not on this glorious occasion of International Women's Day. And thank you so much. And I hand over the podium to the moderators.
Thank you, sir, for a very excellent insight into the genetic predisposition to AKI. Just one question from me, sir. What percentage of population had this chromosome 11 in your study, sir?
Percent patients who had acute kidney injury, all of them had some indication of the changes in the 11 chromosome. All the patients who had.
And that would comprise of what percentage of the total patients who comes from?
Total percentage about 12%.
That's quite high.
12%.
Yeah.
The thing is, all of them may not need renal replacement therapy. The patients who need renal replacement therapy, they are 1 to 2%, and it is those patients who have high mortality. They up to 50% of them will die, and survivors. Amongst the survivors, 1/3 of them will chronically depend upon regular dialysis. That is the crux of the problem. We have to look at those patients.
Did all of them had normal LV or they had impaired LV functions?
All of them had good LV function.
Thank you, sir. Thank you so much. Great insights.
But sir, if you can identify them, then it is easy for you to treat them and the mortality rate will reduce, and identifying is easy.
Identification, we have to first validate in the larger population. First step is to validate the findings. Once you have validated, then you have to go for risk scoring based on genetic analysis. What is the risk? Is it small risk, moderate risk, or high risk? In the high risk, you have to apply all the renal protective strategies.
Okay.
And then maintain their condition in such a manner that the balance is not tipped to the worsening of the renal function.
Okay. Thank you, sir. Thank you. Now, I can't see any question on the chat box. So I think we are moderators are only going to ask.
We will ask Dr. Chaitali, Dr. Jayashree, Anita Malik, Dr. Sunanda, Dr. Madhuri Dikshit, Madhuri, and Dr. Indrani and Anita Malik to unmute, and they can say something about women in anesthesiology in India. How do they perceive the womanhood in our specialty?
Anyone, any
Sir, I want to speak something.
Yes.
That is regarding Indian anesthesiologist, lady anesthesiologist. I am so much grateful to my teachers, whom I met in New Delhi, Dr. Rajeshwari ma'am, Dr. Joya ma'am, Dr. Anjali ma'am, all of them. And another thing is that most of all will be surprised because the thing in 2003 I met Madam Manorama Mittal in my PG assembly, and I still remember that day. She was so much enthusiastic at that time also in 2003, and today I saw her. I want to meet her in person. I don't know if my luck will permit that. I am so much grateful to her, because she started this PG assembly, as far as I know, she started the PG assembly, and it was so helpful to all the PG students in anesthesiology. Thank you, madam. I don't know if she's here or not till now.
Her name doesn't figure here. I don't know whether she's there. Madam,
Most probably
she's there. She's there.
I would like to say a few words.
Yes, yes, please. Yes, please.
As Dr. Chaitali was saying, great teachers, women or men, both. And I would like to especially remember all those lady anesthesiologists who had shaped us more than anesthesiologists, to become more than anesthesiologists, a good human being, a compassionate anesthesiologist. This is what I've learned from Dr. Rajesh ma'am, Dr. Jayalakshmi ma'am, and Dr. Chandrelekha ma'am. There are many other lady anesthesiologists, and they helped a lot of, personality development as well as professional development. And I'm sure our generation, we have many students to come up now. I try to pass on this message to the other generations, that how you become a compassionate and a human being and anesthesiologist at the same time, to look into the perspective of the patient to deal with their problems, and how we should help them and aid them. And I would like to wish all the anesthesiologist team a happy World Women's Day.
Dr. Subhendu Sarkar wants to ask few questions on the subject.
Yes.
So I think he can ask. Dr. Subhendu Sarkar.
Yes. Actually, the question is a bit practical thing. That's what Muralidhar sir had rightly mentioned, that in a tropical country like India, particularly the amount of cardiac surgeries what we perform, at least 30% patients what we get is actually not having some compromised renal function, not very well optimized, and simultaneously, because of the case loads and other, we actually don't give any proper time also to optimize these individuals. And my presentation was on renal function test, and Saikat has very nicely put an insight about the renal biomarkers, which actually fill the gaps, because after analyzing these things, we actually want to prepare our protocol. We want to coin those patients. These patients might land up in AKI or can have some renal issues in the postoperative period, and accordingly. So, are these biomarkers are regularly being used, or as a perioperative physician or an anesthesiologist, when we can start IGNITE? Because obviously for a medical legal issues and other, we frequently refer these patients to review by a nephrologist to get a clearance from their sites and other. Even nephrologists sometimes writes that patient is fit for anesthesia. I had number of times have a fight with them that you cannot write anything about the anesthesia topics and other. The thing is, regarding this, and once this goes to the nephrologist domain, it ultimately goes to a diffuse things and other. So about these biomarkers, and as a perioperative physician, your opinion, particularly my question is to Saikat specifically.
I think that's a very point well taken, Subhendu. I think to the best of my knowledge, the one that is used to somewhat extensively in the West is the NephroCheck point of care testing. It comes like a cartridge and you put in the thing and you do it. I did a little bit of a homework kind of a thing as to how much of it is done in India. Unfortunately, I don't think it is done routinely in clinical practice, except I know there was a publication in the January 23 edition of Annals of Cardiac Anesthesia, where I think Dr. Muralidhar's team did this. They unfortunately, I think this unfortunately or fortunately, their conclusion was that when they did it, I think, sir, if I remember right, 4 hours after the surgery, and then they tried to look into the incidence of AKI, NephroCheck actually did not reveal much. But as far as I could gather, most of the validation with biomarkers in the perioperative scenario has been better off in the cardiac surgical population. To kind of say that AKI is happening, and if you can intervene and treat, you might prevent them to progress further and cause permanent damage. Now, at any point of time, these kind of studies will always have a kind of, I would say, bias, in the sense, the moment you realize that a marker is increasing, you would intervene and do something about it. Most ethical committees will not let you perform a ethical trial wherein you find that a marker is increasing and you do not intervene. So that will be a kind of a bias that would happen with most studies. But what has still, I think it is still very much in India, a little more only on the, I would say, on ongoing research methodologies. But certain nephrology units, a lot of nephrology units in the NHS, UK, and in the US would use NephroCheck on a regular basis. This is to the best of my knowledge.
And I have another small question.
Can I add to that? Can I
yes, sir, please.
add to that?
Yes, sir, please.
Because we have been associated with NephroCheck, what is called as TIMP2, that is tissue inhibitor metalloproteases 2 and insulin-like growth factor. The combination of these two markers is called the NephroCheck, and a value more than 0.3 is supposed to be indicative of renal injury. But in the problem with our study, I'll explain to you why we did not demonstrate that NephroCheck is a predictor of acute kidney injury is probably because of the fact that only one value was done. There was one publication which said even one value is sufficient to indicate acute kidney injury. Based on that paper, we try to reproduce their findings in cardiac patients undergoing off-pump CABG. And what happened in these patients is that preoperative NephroCheck was checked, and post-operatively, 4 hours after the surgery, another value was checked, and it was not repeated again because based on that one particular paper. So the explanation we have is that in cardiac surgery, after once the surgery is during surgery and after surgery, there's a lot of hemodilution occurs. In fact, in this study, the preoperative hemoglobin was 14 grams % average mean, and the post-operative was average of 10, which means the 4 grams less in the hemoglobin, which means that patient had substantial hemodilution. And this could mean that even if the NephroCheck was elevated, it could not reflect in the value because of the hemodilution. So probably we should do a serial estimations, maybe, and then see what happens to the kidney injury and then only come to conclusion. And also probably do in non-cardiac surgical patients where there is not much of hemodilution, for example, orthopedic surgery or something like that, and then see the incidence of AKI, whether it's related to NephroCheck. This is our explanation. And the company people were not very happy with the findings, and they stopped supplying NephroCheck to us. This is the story of the story. And regarding NGAL is estimated in the urine. NGAL did not stand the test of time because NGAL can be raised even in patients who have inflammatory disease process. When there is lymphocytosis and inflammation, it can be increased. So it's not really specific absolutely for kidney function.
It comes from the bone marrow as well. So any inflammatory thing will release it from that side as well.
Correct. And I have another small question to Dr. Kalyan. that Dr. Kalyan has mentioned regarding his preoperative slides for patient posted for the renal transplantation about the assessment of the volume status of the patient. So on that particular phase where no invasive lines and nothing has been placed in the patient, what are the clinical parameters you give stress upon for assessing the volume status of the patient?
Generally, NIBP, heart rate, generally we depend on that. And as I mentioned, dry weight and wet weight will give some insight, and pulse. Generally, clinical only we should assess that before taking into surgery.
If you ask me that question, I will ask you to do ultrasound. Yeah, ultrasound or IVC.
Ultrasound.
IVC.
Bedside echo, as I told.
IVC collapsibility.
Actually,
or
nowadays it is dynamic assessment.
Dynamic
It's
assessment.
no more
Exactly.
static.
No more static.
All the pressure-related indices have.
It's all the dynamic parameters of the fluid.
It's all volume-related,
There's the
dynamic.
IVC collapsibility or the aortic flow velocity is
Yes.
what we have, or the
Yes,
right heart
yes.
functions.
So it
Yes,
has
I
been
mentioned
proven beyond doubt
bedside
that-
echo on the day of surgery. Generally, we assess all hemodynamic.
Yes.
Right.
Thank
And
you,
if
sir.
you
Thank
have
you
a good cardiac output monitor, there are other indices also.
Yeah, ma'am, we have couple of non-invasive monitors are
Non-invasive
already in
cardiac
hand.
output,
Exactly.
yes.
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 Even the thoracic bioimpedance, we can measure the total body water itself by using this Grongor index by just putting the leads and other. So we can use it if we want. We can have the values.
That's right.
Yes. Yes.
Can we request Anita Malik to say something? Anita Malik and Madhuri. And,
Yes, today is Women's Day, and for us women anesthesiologists, it's definitely a day to be proud of, because we are anesthesiologists and women. I think despite the family commitments and household responsibilities for women, they are maintaining and keeping a fine balance of their professional life and domestic front due to their inborn inner strength, compassionate nature, patience, and these are empowered by all these things. And I think this is the reason they are sustaining and maintaining the position of female anesthesiologists in the society. And we, our colleagues, our counterparts, they are now accepting them with open heart. So that's really something. So we women stand today because of all the other anesthesiologists in our society. I think so, and it should be maintained.
Thank you.
I think you said it so well, ma'am. Actually, women are born with this emotion called Vatsalya. And Vatsalya literally is, affection, tenderness, love, something which a mother gives to a child, or a cow gives to the calf, or, a god gives to their devotees. So that's Vatsalya. And mothers and we women are born with that emotion. And as you rightly said, because that emotion is inherent in a woman, they effortlessly multitask as not just a good anesthesiologist, but also as a good mother, sister, a daughter, friend, or whatever you want to call it. I mean, relationships through the whole gamut of people. So I think you nailed it so well. Thank you so much for saying that.
Thank you, Indrani. Thank you so much. Thanks for joining us.
Sir, you all the men's has made us superwoman, and to deal with such kind of the situations. So the power we are getting it from you all only, na?
Exactly.
No. I firmly believe that it's the feminine power which controls the world.
Can I say something, sir?
Yes, yes, yes.
Yeah, my daughter says, that ladies have more salkai and gairais. That is why they can do better multitasking. So than men. So I think that is correct.
Correct.
Salute to all our senior madams and colleagues and juniors for participating in today's forum.
Thank you. Dr. Madhuri, you want to say something? Madhuri?
Thank you, sir. It's a happy Women's Day to everybody. And I would just like to say that I have received a lot of support from my family.
Right.
And my mentors have actually been both men and women. So I have no regrets, and I have received full support for my academics and for my clinical work and for everything. And I'm thankful to everybody who has helped me till today. So I think it's not gender, but it's hard work, perseverance, determination, which decides your success. So that would be my message to everybody. That it's just hard work and determination which can get you. Thank you, sir. Thank you so much.
Thanks for joining us. Thanks.
Yes, sir.
Now, Dr. Manjula, please, are there any more questions or comments?
We don't have any question on the chat box, but I just wanted to know from Dr. Ram to give anesthesia for renal transplant. Can regional anesthesia be the choice for renal transplant?
It depends on.
Yes.
Generally, regional anesthesia is controversial. Epidural anesthesia can be given, but surgeon should be fast and there should be good understanding between anesthetist and surgeon. They might have done many cases like that, and patient should be young patients tolerate, but young patient with this other indications. If the patient is thin and there is single vein, single artery, it can be done. We did in one case, only one case.
No, because I have come across with many of the anesthesiologists, according to them, the renal transplant can be done easily under epidural anesthesia, and they are very happy, and they are saying it is advisable to do under regional anesthesia.
Yes.
So I just
the problem is with the unknown complications. Because there is a chance of complications, every case may not go well. It is because there is no special advantage of epidural anesthesia. Because once complications occur, then we will feel bad about why we have given like that. It is avoidance of complications. Because if it is a thin patient, young patient, and surgeon and anesthesia have done many cases. So due to coordination, they can go ahead with good understanding. Regional anesthesia definitely.
Selection of the patient is needed.
Selection
of the patient is needed.
Selection of the patient is needed.
Okay.
Can I make?
May I add a few things to this, sir? In my experience in UK, most of the times they used to do it under regional anesthesia only. And yes, as Dr. Ram was saying, the surgeons were very fast. They were very clear about it. And of course, the other conditions and infrastructure are probably more helpful in that country to, in the Western world to do these patients under regional anesthesia. In AIMS, we used to do regularly under general anesthesia. But that was an experience to, to do them all in most of the times. We were doing them under regional anesthesia.
Right.
So
the only thing is, they have they come with a recent dialysis.
Sorry, ma'am?
They come with a recent dialysis, Overnight, they go through a dialysis and next day morning at 8:30, they are posted. So that is one thing which we have to worry about when you're thinking about epidural. You have to be very sure about the coagulation status. That is one thing. And second thing, also because of CRF also, they have platelet issues and, other problems. So that again, it's only patient to patient you can decide.
And you cannot give a blanket statement that epidural anesthesia is good for renal transplant.
I agree with.
It depends upon the patient selection and the type of patients you get.
Dr. Kumar, please carry on.
Yeah, so the thing is, the first renal transplant in the world was done under spinal. But the reason we switched from regional to general is because of the coagulopathy risk that was brought up. With renal failure, you do have platelet dysfunction. And so if you're pretty sure about coagulation function, there's no problem with doing regional. But if you do have a coagulopathy or you have platelet dysfunction, then there's a risk of epidural hematoma.
Yes.
So you have to take that into consideration. But otherwise, I think majority of the cases now, at least, are done under general. Tap block is fine. Local infiltration by the surgeon is fine. Any peripheral type of nerve block, it is fine. But like outlined by one of the panelists, that if you do have coagulopathy, you do run a risk. And even sometimes after dialysis, the coagulation function may not be fully normal.
Yeah.
Yes, yes.
And one more comment I just wanted to say that biomarkers, regarding biomarkers, they are still in the category of research, and ethical committees are really not giving the permissions to conduct those kind of the research. And it is practically how useful in the day-to-day life is still a question mark. Dr. Kumar wants to say something regarding this, is most welcome.
That is right, yeah. Dr. Kumar?
Can you repeat the question? I was a little distracted by a patient.
Regarding biomarkers are concerned, it is for the research purpose only till now. And in the routine practice, I don't know how useful it is, and it is going to be. I want your comment.
I think these biomarkers will be increasingly available. And like you said, right now it's not a routine practice. But I think in the future, identifying patients at higher risk, especially those that might be at risk for pharmacogenetic problems with immunosuppressive therapy, all those items, we are going to be moving into precision medicine, which means that we will get all this information in the future. But right now, it's not universal.
Okay. Thank you, sir.
There are no guideline recommendations as of now. We have to wait for the guidelines.
Okay. Thank you, sir. Thank you.
So that we can apply it in our day-to-day practice. With that, I think we'll Manjula sir make the last comment and hand over to Abhijit Singh, please.
Okay. So now I'm handing over the mic to Dr. Abhijit Singh to conclude the session and vote of thanks.
Thank you so much, Dr. Manjula Sarkar. Well, friends, it was a wonderful webinar. Apart from the excellent presentation by all the speakers, starting with Dr. Chaitali, where she dealt with pharmacology, renal physiology, which is, I think, basic for understanding of any renal, whether it is renal functions or it is renal management and whatever. Thereafter, renal function tests, which we normally ask, which we normally require for any patient who is coming for surgery, and what kind of renal function are required and what significance do they have. I think that was very well highlighted by Dr. Subhendu Sarkar. And thereafter, Dr. Saikat Sengupta spoke on biomarkers in renal disease, and I think there was just now there was recommended by Dr. Kumar Bilani as well. Dr. Kalyan Ram dealt with the anesthesia part, which again is very, very significant, for any anesthesiologist. And Dr. Kanchi with regard to the genetic predisposition to kidney disease. Well, friends, this was a very important day because in India it's apart from Holi, it was the world, it was the International Women's Day as well, and we had the presence of a lot of learned ladies amongst us. And as Dr. Mitchell also has put it, I think the Women's Day is not to be celebrated once a year; it needs to be celebrated every day, because the contribution of women to society, to our professional life, I think is tremendous. They are sort of a embodiment of patience, love, sharing and caring, grace. We learn so many things from women, how to conduct ourselves. Hats off to them. The kind of multitasking that they do, whether it is a professional life or it is at home, looking after the children, looking after the home life total, and of course the professional life. They are no less contributed to the professional, professional life in any institution wherever they're working, whether it is medicine or it is not non-medicine field. Everywhere they work, I think they have made a place for themselves. Not only just made a place for themselves, a very important place for themselves. Hats off to all the women who joined here today. And I conclude with thanks on behalf of the President of Indian College of Anesthesiologists and all the executive members of the Indian College. Thank you so much. We meet next Wednesday. That will be the webinar on laryngotracheal surgery, perioperative concerns. So friends, till we meet again, good night, take care of yourself.